Thank you. Take two. So the indications of ureteroscopy have obviously increased, and we are using it more often than we have ever done. And there are lots of circumstances. I've just shown you the foreign body, then the nephrostomy tube, but there are lots of specific circumstances where other techniques may not be more appropriate, or they might be more risky, or they're contraindicated completely. So, there was the statement by Guido Gisti, sky is no limit for ureteroscopy, and you can extend the indications. I completely agree, and I do it for all of these cases. So if it's a very large stone, pediatric and elderly stones in solitary kidneys, diversion, if it's an anomalous kidney in pregnancy, bleeding diathesis, obese patients, infections, or bilateral, all of these cases would fit in the remit of ureteroscopy. And why are we doing more ureteroscopy or stone surgery? Because if you look at the weather and the association of weather, there's been an increasing trend, both proven stones and of colics over the last 2 decades. So obviously more stones are there, and we are doing more of them. And again, we look at the publication trends, it's a very similar thing. More ureteroscopy and PCNL are being done and published. So, if you look at large stones, so this is a systematic review that was done about 5-6 years ago now. When you look at large stones, stones between 2 and 3 centimeter, no major complications. The stone-free rate was reasonably good. It was above 85%. If you compare that to PCNL, you can probably never say no major complications, because you would have some complications. Similarly, when I looked at my large stone data, this is published 3 years ago, the stone-free rate was 84%, but there were only 6 Clavian 2 complications, and they were related to urinary tract infections and no other complications. And these are large stone with a mean stone size of 3 centimeter. When you look at obese patients and morbidly obese patients, it is clear that although the stone-free rate is lower than what you would expect from PCNL, it's not bad, it's 83%. Complication rates are usually Clavian 1 or 2. There was only 1 Clavian 4 complication, and there is overall, compared to obese, morbidly obese have a slightly higher rate of complication, but again, they are all low Clavian scores, not high Clavian scores. If you look at pediatric stones, large stones in pediatrics, this is our data, stone-free rate of 89%, 0 complications in our data. And this is a prospective data that was published. And these are, for pediatrics, 1 centimeter I would say is reasonably large. And we did it in exactly the same technique as I said before, 2 guide wires, semi-rigid ureteroscopy, but we have a 4.7 for that, and then a flexible ureteroscopy, which is a standard flexible ureteroscopy. And at the end, we always check the chelicus, and we have a twin surgeon model. So I pair up with a pediatric urologist, so he looks after the patient before, he's there with me. If they need urethral dilatation, whatever, he does it. And then when it comes to doing the laser fragmentation and the ureteroscopy, I take over. And again, it can be done safely in medium and high volume centers. You don't have to be a very high volume center to do it safely. We also looked at a systematic review before, and what we found is for pediatric patients under 6 years, the rate of complications and the failure rates are very high. And that was clear, that if you are under 6, below 6, there's a much higher rate of failure and complication compared to those above. So now we tend to pre-stent, or some of them who are really below 6, we tend to pre-stent. Of course, we'll try and do it at the same time, but if it's not possible, and then bring them back for a second procedure. In elderly, again, it's very safe. The only thing I have to warn in elderly, even though it's safe, there is a higher risk of urinary infection or urinary retention. So routinely, I don't place any catheters, but for this group of patients now, if I'm worried, if I think, well, they might go into retention, they've had prostate problems before, or they are on medications, BPH, I'll have a low threshold for putting a catheter. But otherwise, again, the stone-free rate is very high. Our mean day case rate, most patients went home the same day, but I'll have a low threshold now, having seen my results, to leave the catheter overnight. Bilateral ureteroscopy, this was a review again we published, one of the papers was ours in this, we published, and we looked at 2 time periods. In period 1, the complication rate was a lot higher, it was 41%, and in the second time period, which was the last few years, the complication rate dropped to 12%. And that probably is because the instrument size is smaller now. People understand renal pressure a lot better, although I don't think we completely understand it, but we are more careful because you see what can happen. And generally training is better and the volume has increased. So we are slightly safer than what we were. So bilateral ureteroscopy, the complication rates have dropped. And what we see is the volumes for people who do higher volumes of cases generally. So if you do more volume, the complication rate comes down. This is a recent one on bleeding diathesis. So people who are on anticoagulants, what's the risk with them? The thrombotic complications were exactly the same. There was no difference. But when we looked at the bleeding complication, in patients who are on anticoagulants, as you'd expect, there was a slightly higher rate of bleeding or related complications in the treatment arm. So for these patients, I think a patient-centered approach is needed. If you think they can safely stop the anticoagulants, they should. If you think that they can't because there is a contraindication or cardiac indication, then you can operate on them, but the risk of bleeding is slightly higher than otherwise. We've looked this in patients who had proven infections and stones. So is there an association between infection and stones? And we looked at prospectively consecutive patients who had urinary infection, more than 100 patients, the age distribution was equal. 81 of them, so 78% had a positive pre-op culture. The others had symptomatic UTIs but not proven on culture. And when we look at the association, at 3 month, at 6 month, and at 12 month, the stone-free rate, so 96% was stone-free. At 3 months, the infection-free rate was almost 90%. And at 12 months, as the stone-free rate, as some of them had recurrences, the infections also starting to come back. So this was clear that if people have got stones associated with infections, treatment of stones can lead to them getting infection-free. So this was a strong message because we sometimes don't know. So now I would tell my patients, not everybody would become infection-free, but there is a high chance that if you treat your stones, provided the stones don't come back, you'll remain infection-free. Retrograde ureteroscopy is always challenging, and this was a review we did recently. The success rate is variable between 55 and 80%. Complications are acceptable, but there are some tips and tricks that we can learn from what people have published. Using a flexible cystoscope and ureteroscope, using a super stiff wire if you need for negotiation, access sheath if indicated, and having fluoroscopy to delineate the anatomy. And don't be afraid to combine anti and retrograde. Sometimes that's what you have to do. So if retrograde approach on its own doesn't work, so you have to sometimes combine it with an anti-grade approach. In solitary kidneys, again, we looked at 12 studies over almost 700 patients. Good stone-free rate, 85%. Complication rate was 17%, slightly higher than what I would have expected. But most of them are Clavian 1 or Clavian 2, related to either UTI or transient fever or transient hematuria. Again, very safe when it comes to doing ureteroscopy in solitary kidney. In pregnancy, again, we divided into 2 time periods. Time period 1 was from 1990 to 2010, and then more recently, in pregnancy, it was the other way around. There were more complications in the papers published recently. And I think it's partly because, when we are doing more cases, we are taking on more challenging cases. The bottom line is it should probably be done in high volume centers with experienced endourologists, with the obstetric team, because it is not just the patient, you also have the baby to worry about. So in pregnancy, it is safe. It can be done, but be aware that the complication rates have risen mainly because either we are doing more of them or we probably need to be careful and do it along with the obstetric colleagues. So more ureteroscopy is being done with a slight risk in overall complication. So cholesterol diverticulum is always difficult. The stone-free rate is not as high as some of the other things, but they are difficult no matter how you treat them. More patients became symptom-free than stone-free, and this review concluded by saying that the overall quality of evidence was quite poor, and there was no long-term follow-up because you don't know, you might clear it at the time. There was no long-term follow-up for any of these patients. In anomalous kidneys, which we have just recently looked at, which has been submitted, the mean stone size was high. The overall initial and final stone-free rate was not bad, 70 and 80%. The overall complication rate, again, most were Clavian 1 or 2. So in these patients, you can achieve a decent stone free rate, although they're technically challenging. But the problem is they're challenging whichever treatment you do. They're challenging with PCNL, they're challenging with lithotripsy. The stone free rate are sometimes not very high. But the risk of major complications was low in this from the outcome. Why are we doing more? Are we really doing more? This is the trend of ureteroscopy over the last 2 decades. Everywhere, this is country by country, everywhere we're doing more and more ureteroscopy. So clearly the indications for ureteroscopy has risen over the last 2 decades. And we are doing it for lots of different variety of things. And look at lithotripsy. I think people are probably still doing it. It is probably still the commoner treatment, but the indications are coming down because you've got ureteroscopy which is achieving a higher stone-free rate and the complication rates are coming down. Thank you.